about the different types of MRIs, CT scans, and things like that. These are the different types of tests that we are going to use to diagnose the different type of respiratory disorders. So we know sputum is the secretions that can be tested to determine what kind of medications we're gonna need to give to, so if it's bacterial, viral, whatever is going on that is causing the symptoms. And then they can also do the nasopharyngeal, so you know that swab that they put back there that tickles your brain, it's very similar to that. They can also use the throat culture, so they'll go right back with the same swab and swab the back of the throat. And then arterial blood gases can be used to determine if they are oxygenating well enough. Chest x-ray, you know, just visualizing the chest, make sure that there's not any pneumonia, any atelectasis, anything that's causing obstruction in the airway. And then the bronchoscopy is going to be actually visualizing the different anatomy of the lungs. Bronchial specific. So nasopharyngitis, this is basically what you think of when you think of like a common cold a little bit. So you're just gonna have like nasal drainage, you'll have a sore throat. You won't have, like, fever is not as common, but if there's enough of like complications due to the other symptoms, it can cause a fever. So this will also cause bronchiolitis, pneumonia, and ear infections. So remember how we had talked about the eustachian tube having access from the ear to the throat? So if there is this infection in the nasopharynx, then it will likely get to the ears and cause ear infections. So most of the treatment that we're going to do is going to be supportive and to treat the symptoms. So we want to make sure that we are treating the fever, we are allowing them to get as much rest and fluids as possible, and making sure that their airway is clear too, so that they are able to adequately, you know, breathe. Because that can cause, you know, all those other great issues that come. And then skincare, you know when you blow your nose a lot and it just gets really red and irritated and chapped, we're just making sure that we're using like Vaseline in that area, anything to keep it moistened and not dry to cause skin breakdown, okay? Acute pharyngitis, so this is what you would think of when you think of strep throat, okay? It's the same thing, so it's gonna be the streptococcus infection. There are a lot of different complications that can be caused from this. The biggest one we really have to worry about, and that's gonna be the most common, is gonna be that otitis media or pneumonia. The other ones are just kind of less common, but can happen. So the signs and symptoms, whenever you think of that sore throat, so they're gonna have trouble like swallowing, they're gonna be coughing, they're gonna have dysphagia, hoarseness, and what would cause the anorexia? Yep. Mm-hmm. Yep. Yes.
In the book, it does like differentiate like viral from bacterial. Is that something that we're gonna need to know? How to
I would just
differentiate the two?
focus more on talking about how the most, like the main common is gonna be that streptococcus. So I would focus more on strep throat, but I will go back through.
I just, yeah, okay.
yeah.
I just wanted to know.
Yeah.
If we needed to be able to.
And I can
really
clarify that too.
differentiate them.
Yep. I like to go through everything and then kind of review the test. I don't like to teach the test. You guys, you know what I mean? We need to know all the information, it's all relevant. Okay. Then diagnosis and treatment, obviously we're gonna have to take a culture swab of the throat just to make sure that we're using the appropriate medication to treat, and we will be using penicillin more than likely to treat the pharyngitis. So you can see in this picture like how red and irritated this looks. And I'm sure, I mean, we've all pretty much have had strep throat before. I would not wish it on my worst enemy. Like not being able to swallow and just feeling like you can't breathe properly is not a very good feeling. So these children are just probably gonna need a lot of TLC, a lot of an extra attention and all that to help keep them comfortable. So croup. Has anyone ever heard of croup before? Yep. There are a lot of different types of croup, and I know your book talks about a few different ones as well. We are mostly going to be talking about the laryngotracheobronchitis is what we are focusing on. Okay? So this is going to be most common in very young children, so anywhere between 3 months to 3 years old. And the croup is causing edema in the subglottis. So this could be caused by viruses, allergies, or just having the epiglottis area be very weak. That can cause this inflammation there. And we all know that barking cough, so it's not, you know, when you're out in public and you hear that and you're like, oh, that does not sound right. Somebody needs to take their baby to the doctor. It's gonna be that like kind of sound. Don't bark. I have to give examples the best I can. But that's gonna be the classic sign. That's when you're gonna know that they have those issues. And it can cause respiratory obstruction. So here in the picture you can see the inflammation is like really restricting the airway there. So we just have to be very mindful and making sure that we are treating those symptoms to reduce the risk of obstruction. So what are some type of things? So you know how I said palliative here? So we're gonna do breathing treatments, but is there anything else that we can do to kind of just ensure that they are oxygenating well?
O2?
Yep. Uh-huh. Yes. That's really important. So we're just trying to make sure that, again, I like to use, because the book will use supportive a lot, but I like to use the term palliative too, because it kind of encompasses also just keeping them comfortable. Because a lot of these respiratory issues are very uncomfortable for children. So we're just trying to make sure that we are keeping them at a comfort level that they are able to still get the adequate nutrients that they need, and we're not causing any other issues. Because if they're in distress, they're not going to want to eat, they're not going to want to drink. They're going to be lethargic, we're going to have different issues like that. So we are trying to make sure that they are comfortable, that we don't cause any other issues like dehydration, for example. Okay?
So like increased fluids.
I would say honestly for all of them. Rest, increase fluids, manage any type of difficulty breathing. So you can do like the orthopedic position, but for children it's easier to do like sitting Bowers. Okay, so epiglottitis. Has anybody ever heard of this one before? Okay, this one is actually really easy to spot, which is nice because, like I put up there, it is a medical emergency. So if this is happening, it is very, very possible that a child can die. As if you can see the treatment, that is a pretty invasive treatment. A trach, intubation, those are very invasive treatments. At this point, there's no rebreather, there's no nasal cannula, nothing. It is, we have to do something or this child can die. So this is gonna be edema of the epiglottis. So this is right above the vocal cords. And it's gonna be most common in children 3 to 6. So the key sign and symptom for this one is, again, very universal. So when you see this, you're like, oh, okay, it's epiglottitis. I know what it is. So the child is going to be sitting up, leaning forward, mouth open, and just uncontrollably drooling. They cannot stop how much they're drooling. It just comes, and it's not a good look. It's just, but again, you'll know exactly what it is because of how distinct those are. Like, that's the universal sign. And then high fever. Okay? And you can see in the picture here, I don't know if that's a good picture. Let me try to see if I can find one example of like a child in that position to it. Sorry, I was working on this after work yesterday, eating chicken nuggets in my bed with my dog. I know. It's a rough life. I had a patient who had a 46 blood sugar because she's been so psychotic that she hasn't eaten or drank anything in like 5 days, and she's diabetic, so I had to give her IM glucagon. And it only went up to 68. Okay, so we call this a tripod position. So you can see they're like completely humped over, trying to get as much air as they can. There's kind of an example of a child doing that as well. This isn't as severe, but that just kind of gives you an example of that like hunched over look that they would have. And again, this is just a mechanism for them to try to get as much air as they possibly can. Okay? Then we will do IV antibiotics while they are, after they're intubated or given a trach. And then the American Pediatric Association also says that giving the flu vaccine is evidence-based practice for reducing the incidence of epiglottitis. Okay?
So they can get rid of this eventually, right?
Hmm?
So they can just get the trach taken out.
Hmm? So this next slide kind of goes over the difference between croup and epiglottitis. I just want you guys to review it a little bit. We know that severe stridor is also going to be a sign of a medical emergency as well. And then also they talk about the beefy, red, swollen epiglottis, which can be visualized when using an otoscope in the back of the throat. So you'll be able to see that and know that, the child is being affected by epiglottitis. And And again, they'll have that inability to speak because their airway is so restricted that they're not even able to close their mouth properly to like get any oxygen. So next we're going to talk about bronchitis versus bronchiolitis. So the bronchitis is going to be typically about secondary to a cold or another communicable disease such as any type of like upper respiratory infection. So this is going to be like a secondary disease process associated with that. So this is going to have that hacking, unproductive cough. And then, well, it'll initially have that, and then it moves to productive cough, which is an excessive amount of sputum.
So one affects bronchi, one affects.
So that's kind of how you can tell the difference. And then also, the signs and symptoms are going to be a little bit different. So the bronchiolitis is going to cause a lot more like wheezing and tachypnea. So it's going to have more issues with the lungs because think about it. Bronchitis is affecting the bronchioles. So it's up here. And then when you get to bronchiolitis, you're much lower in the lungs into the bases where there's a lot more of that gas exchange. So this is going to have more effect on the way that the child is breathing. And again, it's just, we're talking about the symptomatic care. Because, I mean, when you think of like when you get a cold and even the flu most of the time, they just tell you to get rest, fluids, and things like that. They don't even treat it. So a lot of these, I want you to really focus on where in the body it is. Because if you think of where in the body is affecting, you can come up with the different symptoms that it's going to affect. So we know that basically with most of the respiratory disorders, that the treatment is going to be symptomatic or palliative. So we're keeping the child comfortable. Then bronchiolitis can also, lead to hospitalization, and they will just need to make sure that we're keeping strict I's and O's. We're able to do frequent vital sign monitoring, so we'll be looking at respirations a lot, their O2 sats, things like that, to just make sure that they are getting appropriate oxygenation. And then with the infants who have bronchiolitis, it has been found that they may develop a hyperactive airway or asthma later in life. What's a hyperactive airway?
Very reactive.
Come on, y'all.
It's reactive.
Give me a little bit more to work with.
Isn't that the muscles involved in your cells?
Yep. So the hyperactive airway, so when you think of it, it's kind of associated, so it's similar to asthma. So this hyperactive airway, you're more susceptible to have bronchiolitis or bronchitis chronically. So we all know like chronic bronchitis where you always have those coughings. Every single time you're getting sick, it becomes bronchitis. And then you have that cough, that irritating cough for weeks. So it makes you more susceptible to have chronic bronchitis or bronchiolitis. Okay? So then we just have to make sure that we kind of educate the parents, like, because they have had this disease process, we just need to ensure that we are being mindful of monitoring their airway and the symptoms that are associated with those kind of illnesses. Okay, because if the parents aren't educated on what to look for respiratory distress and things like that, they might not know that there is an issue. So, and we also, something else that we really need to remember in pediatrics, we always have more than one patient. We have the patient and their caregiver that we do have to help educate and support. younger than 4 for bronchitis, and then bronchiolitis was 6 months to 2 years old. It can, I mean, obviously they can have it at any age, but this is when the most common incidence is. And then also I put 50% of cases of bronchiolitis are gonna be caused by RSV. Okay? So then we just have to be very mindful of making sure that we're treating RSV as it comes as well, so that it doesn't develop into something like bronchiolitis. And we know too, when I talk about palliative care, with the respiratory disorders, positioning is very important. And we know like the tripod position and things like that, that opens up the airway and allows for more oxygen exchange is very important for comfort level as well. These ones are gonna be for because they have the like the drainage and the cough, and you've got like coughing and kids. Kids, what kid do you know covers their cough? None of them. Not a single one. They get it So influenza. I feel that we're all probably pretty familiar with flu. I want you to just, I was thinking a really good extra credit question would be like, when is flu season?
Oh, it's October.
October
To
March. December.
Yeah.
March.
April.
A little bit more.
Almost October through March.
Lori, you just yelling things at me at this
I
point.
can't see over there anyway. I'm
Oh, why are you over there then?
Oh, because these are your seats.
Don't ask.
What do you mean you new seats? Don't ask. That makes me feel like I should ask. That's suspicious. Oh my gosh. Okay. I'm not gonna ask. We're gonna talk about the flu. I hear you. Okay, so I wanted to have this little picture here so we can talk about the actual morbidity associated with the flu. That's a significant amount of deaths associated with the flu for something that, one, has a vaccine, and two, if treated when the symptoms like first onset, so within like that 48 hours of onset of symptoms, can be managed pretty easily at home. So we know that the same thing is going to be like increasing fluids, that palliative care, treating symptoms. You can use like Tamiflu, but a lot of people don't use the Tamiflu due to the related adverse effects that come with it. They're just, it's not great. We also want to make sure that we're doing that nasal swab. And then the actual nasal swabs, the little test strip has, you get the swab, you put it in the solution, mix it around, and then you put the actual flu test strip into the solution, and after 10 minutes, it will read for A or B, and it will let you know which type they have. A is going to be viral, and B is going to be bacterial. So you can remember that B is bacterial. Okay? Remember that? B is bacterial. There you go. The more you know. Okay, so then the signs and symptoms, pretty much what you think of with the flu. You are going to feel awful. You are going to have a high fever. And because of that, you'll have the chills associated. You will have the lethargy, the fatigue, muscle aches, runny nose. You might have sore throat. You might have a cough. But more likely, you'll just have that feeling with fever. And then we know prevention pretty much is going to be basic hand washing and getting your flu vaccine. You should always wash our hands. With soap, not just water. That's what I have to tell my son all the time. I'm like, just because you put your hand in hot water for 5 seconds don't mean they clean. But that's fine. Thanks for coming to my TED Talk about hand washing. Alright, next one we're going to talk about is RSV. So this is another one that they talk about in the news a lot. You know, you see all over social media, don't kiss my baby. You see it all the time. And we know that that's going to be mostly associated with direct contact. So we're going to be very careful because this infection causes thick mucus. So that's going to cause that bronchiolitis that we had talked about, and also pneumonia. So it can be, there's a lot of different strains, there's a lot of different ways it can be transmitted. It's just really important that we are able to recognize the signs and symptoms and then make sure that we are keeping the infection to just the child. That's very important because this is kind of one of those things that like they will say when you are on the unit taking care of a child with RSV, you would do like cluster care. So you would go in there and you would do what you need to do, and then you would only try to take care of patients with RSV. Because if you think about it, if you have a child with RSV and then your other patient has some kind of immune disorder, it's very, very high incidence that you can take that RSV with you that you're caring for, the other patient, and take it to other ones. So it's very, very important that we do standard precautions and things like that.
Droplet or airborne precautions?
They would be, oh, I thought I put them there. Hold on. Not necessarily after, it just depends. I mean, just because the transmission can be through indirect contact, it's just really important that the nurses do use PPE and things like that. I don't think it would be just like a specific isolation, but just being mindful of transmission.
That just seems like it should be droplet. Like I feel like you would wear a mask to prevent from giving it to your immunocompromised patient.
Right. Well, luckily in units like that, I mean, hopefully the charge nurses are educated enough to not put patients together, like your assignment and this person's assignment. You know, they would try to separate them so that you wouldn't have somebody who's more susceptible to getting sick. Really important to do that. So the early symptoms are going to kind of look similar to the flu, and then late is going to cause tachypnea and tachycardia. So the respiratory distress. And I wanted to ask you guys, what are some symptoms of respiratory distress in very, very little ones? Nasal flares, retractions,
Nasal flares, right?
grunting, use of accessory muscles. Anything else?
Is it Nair flares one of them?
Yep, got that one. Those are going to be pretty much the three biggest signs that they are struggling to breathe that we are going to have to be very mindful of and observant of. And obviously, like if they're cyanotic, they're visibly cyanotic, obviously they're probably not oxygenating well.
So when we have like a crying, like we need to go work.
Mm-hmm. Yeah. And I have a lot more fatigue too. So then also treatment's going to be symptomatic, and then they can use antiviral medications, but they don't always decide to. And any viral infections, I can never really explain it because sometimes they're like, oh, let's use a medication, and other times they're like, oh, it's not really worth it. So that is something that even I struggle with, like why are we using it sometimes and why are we not using it other times? That's been on my list of evidence-based practice to look into. I will have to look into that more. So if anybody's interested, just let me know and I'll let you know. So pneumonia. This is also one that can be caused by bacteria or a virus. So this is going to be that inflammation of the lower lobes. So there's going to be fluid in there. So what would we hear when auscultating?
Crackle.
Crackles. even wheezing sometimes too. Stridor, they might have some issues breathing. Not as likely, but possible. So we're gonna hear decreased breath sounds when we're auscultating. And they'll have that tachypnea because they're trying to, breathe, and it's very hard because of the inflammation and fluid that's collected at the lower lobe. They're gonna have that retractions that we talked about, and even possibly they could be cyanotic. And they're gonna have chest pain because of the pressure of the fluid. So we're just gonna need to make sure that we are making sure that they are comfortable. And we can diagnose it by culture specimens, and they can do that of the nose, the throat, or sputum. So they can use any of those to try to diagnose pneumonia. And then also, what's the other one?
X-ray.
X-ray, yep, perfect. So the treatment, we're gonna use fever reducers. We can use supplemental oxygen if they are having a hard time with their gas exchange. So we can do nasal cannula, any type of rebreather mask. And then they can use amoxicillin is gonna be the main medication of choice. And then again, rest, fluids, cough suppressants if the cough is debilitating enough to where they feel that, oh, okay, it needs to be treated, they will use that as well.
How common is it?
It's actually very common because a lot of the time they'll have like the upper respiratory infections, and then it causes so much secretions and all these other things that it ends up building up fluids in their lungs. So it actually can be pretty common, but this is going to be secondary to a different disease process. So you know how it says like viral or bacterial? It's going to be secondary to those. Even the flu. Flu causes pneumonia as well. Okay, take 10. Actually, 15. There's a picture up there of the, just like, you can't see the structures, like, you can't visualize the throat as easily because of the tonsils kind of blocking the view. So, really the only signs and symptoms are going to be that difficulty in swallowing and breathing, and really just because of how enlarged the tonsils are. That's really the only reason it's going to cause those things. So I just think if you are to remember anything, just think about what it looks like and how that would affect swallowing and breathing. Most of the time, if they are constantly getting infections and they are constantly obstructing the throat, they are going to remove them. They can use antibiotics to treat, but it's kind of like ear infections, when they put the tubes in. It's very similar, so they feel like, okay, this is just getting ridiculous. They're having way too many, they're obstructing, we just need to take them out. So they will try to take them out as young as possible, because after like 16, getting your tonsils or adenoids removed, it is so much harder to recover. It is a very, very, very painful procedure in young adults and adulthood. So they're going to try to get them removed as soon as possible. And then the gargles, ice, lozenges, fluid, and then pain relievers, all of those again are going to be that palliative care to just make sure that their comfort level is okay. And the main complication associated is going to be that post-operative hemorrhage. Why do you think that is?
You can't visibly see it.
There you go. Yep. So think about the anatomical location of the tonsils. So if they're in the back of the throat, if you're bleeding and bleeding and bleeding, it's going to go right down the throat. You're not really going to be, and if it's like something that starts kind of lighter and picks up, they might not even notice how much is actually, how much they're hemorrhaging. So they're going to be very, very mindful of that. So that is going to be some kind of, the type of nursing interventions we're going to be very mindful of is monitoring their bleeding after surgery. Next is asthma. So the main 3 points is gonna be that constriction, the swelling, and the mucus. So all of those play a part into asthma causing issues for the child. So the main triggers are gonna be anything from as common as dander from pets, sometimes food, passive smoking, or, secondhand smoke, things like that, third-hand smoke, anything like that can cause irritation to the airway. Very strong odors even, so if they're just again, irritation to the airways. So we know asthma attacks, we're gonna be trying to get a bronchodilator so that we can try to open up the airway. And then they're probably going to have a daily use inhaler as well. So they will be trying to treat the symptoms to mitigate any issues. And so we know status asthmaticus is going to be a medical emergency. They're going to have that respiratory distress, similar to status epilepticus, is going to be not responsive to medication. So they're like, okay, we're trying to get this, under control, and we're not able to. So they will be immediately admitted to the ICU for respiratory management. The main symptoms we're gonna see is that wheezing and orthopnea, and then increased pulse and respirations, mostly just because they're trying so hard. The fight or flight system's gonna kick in. I can't breathe. I'm panicking. My pulse isn't up. I'm trying to catch my breath, and you're unable to do so. So that would make you probably pretty nervous if you couldn't properly breathe and oxygenate. So these patients can have a lot of different symptoms associated with that. And then sometimes they'll have inflammation with the nose and sinuses just to kind of show that irritation as well. The only way that it can really be diagnosed is just by looking at history and physical exam. They can see that, okay, they've been having this overactive airway for a while now. They're constantly having issues. We're having to use bronchodilators every single time their airway is obstructed or they have that constriction. So they're going to try to use different management and the inhalers to try to see if that is helping or not. And then again, the education. So we're going to try to talk about the different triggers. Is there anything that you're noticing before you have these asthma attacks? Is it every single time you're around your best friend's dog? Is it every time that you walk outside and there's a certain kind of tree around? Is it when the pollen count is up or things like that? So if we're able to identify triggers, we're able to make sure that the asthma attack is a lot less severe and more manageable for the patient. So just want you to be familiar with the medications, okay? Just knowing the difference between the bronchodilators and what they would use as daily use and what they would use in emergency. Okay, I want everybody to look that up, and then on Thursday, it's the first thing we're going to talk about. Okay?
Are you talking about names?
Yep, just show me what we would use and then why we would use it. So why are we using a bronchodilator? Because it does this. Why are we using, you know what I mean? So we're like, oh, okay, it's because it opens the bronchus. You know what I mean? Okay. So we're going to kind of put 2 and 2 together a little bit. Cystic fibrosis. So cystic fibrosis is going to cause 2 main defects. So it's going to cause increased viscosity of mucus gland secretions, and then a loss of electrolytes and sweat because of abnormal chloride movement. So it affects a lot of different parts of the body. So we have to remember not only is it a respiratory disorder, but it's going to have a systemic effect. So the biggest thing, obviously we're gonna have the respiratory system symptoms. So they're gonna have increased respiratory infections and then hypoxia that can also lead to heart failure, emphysema, and wheezing. So they're gonna have those hard time breathing, the irregular respirations, things like that. Like you can see obviously that their lungs are affected. Next is the pancreas. So a lot of the time the mucus can cause obstruction. So the feces are going to be large, very copious amounts of feces. They'll be fatty, very foul smelling, light in color. It's going to be a very big indicator that there is something going on with the pancreas and cystic fibrosis. Then it kind of talked about like salty skin because of the electrolyte imbalances. And then also infertility issues. The female patients can have issues without having periods, so they might have amenorrhea, and then males can sometimes just be completely sterile. So the treatment, again, is going to be palliative and supportive and managing the symptoms. So we are going to make sure that we maintain that electrolyte imbalance. We're going to make sure that because they're having all these issues that cause the thickened mucus, they're going to have issues with nutrition as well. So we need to make sure that we're ensuring that they have adequate fluid intake, they are not becoming anorexic due to appetite loss because of the amount of mucus and secretions that are happening. And then we're gonna just make sure that we do immunizations and antibiotics if they do have, since they have those increased respiratory infections, we may have to treat those very aggressively because it can cause all these other symptoms because of the way that it affects the lungs. So you can kind of see in the picture that, look at all this mucus in here that's just completely obstructing the airway from being able to oxygenate as it needs to properly, and then the anatomy of like normal anatomy. The anatomy of a healthy child. This is a lot less common. So this is called bronchopulmonary dysplasia. This is only going to occur in premature infants who have been using oxygen and ventilators due to having decreased what when you're born? When you don't have it because you're premature? Surfactant. Yes, correct. So these are the only population that will be affected. Okay? Because these are the only people who would have issues with that. The only way you can prevent this is to prevent premature births, which is not always very easy to do. So it's kind of like, oh, just don't have your baby premature. But again, it's not always that easy. So, and this is going to kind of, the symptoms of this will, again, be, since it's the newborn, and we kind of talked about those 3 hallmark symptoms, the use of accessory muscles, and also another one, clubbing of the fingers. Why would they have that?
Chronic
hypoxia.
Mm-hmm. Yep. Failure to thrive. What do you think for that one?
I don't know if they can breathe. Their cells aren't getting good oxygenation, so they're not growing well.
a lot of different reasons. Remember how we kind of talked about with trying to do the palliative care and keeping them comfortable. If you're this small, you're premature, you're already having these kind of issues, you're probably not feeding well either. Because think about it, when a newborn is feeding, there's a certain position you have to have them in to feed correctly without, causing any aspiration. So it would be very challenging for these premature babies or infants to, have the normal rate of growth. So their growth is going to be inhibited due to the respiratory issues. Irritability caused by hypoxia. So if you can't breathe correctly, remember how we were talking about that irritation, the panic of not being able to catch your breath is gonna cause them to just probably be very restless. When you think of just any infant, anything, when they're very uncomfortable, they're squirmy, they're grunting, just kind of think of it like that. So again, we're just very, 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 very honing in on palliative care, which is just something you should just know, And then there is no cure. So this is going to just be sure that we are trying to reduce that inflammation so that we can wean the infant as soon as possible from the ventilation, from the supplemental oxygen, whatever that might mean. So it's usually self-limiting. They will get better and it will be fine. But it's going to take time. So just don't have a premature baby. Moral of the story. All right. So SIDS. Did you know that Hamilton County is actually one of the leading counties in the entire USA with incidence of SIDS? Yeah, very high incidence. So when we think of SIDS, these are going to be that sudden, unexplained death of, an infant anywhere between 2 weeks to 1 year old. Again, the hallmark signs for this one, what they were saying is, a constant in every single case. They pass away while they are sleeping, and that you never know that they're in distress. They don't cry. They make no type of noise or indication that they are in distress. So you can think of how detrimental this would be to any parent. They had no idea. There was no way that they could have saved their child. So that's why I kind of put down here, we just need to be very supportive of our parents in the grieving process. So we know to allow them to hold their child even after they've passed, allow them to take pictures, allow them to continue to bond. That's just very important in the grieving process, okay? And I'm sure we've all heard of the ABCs. What are the ABCs of safe sleep?
Alone on their back in a crib.
Yes. So with that being said, most of the time they've noticed that increased incidence is happening when the infant is prone. So there used to be some evidence that pointed to, the infants being prone, and then because they weren't able to move their head as easily, they would aspirate on their own vomit in the middle of the night. That was very common.
Because of that statistic that you said earlier, there are a lot of agencies specifically in this area that provide cribs.
Yeah.
Because of that high incidence.
Yep. There's Every Child Succeeds, there's the 3 C's, there's a whole bunch of them.
So I have a question regarding these. So I understand that we gotta put the baby on the back, whatever. But majority of times see it's not happening from being in the beginning.
No. It's
Happening like
just,
a girl.
okay, so it's kind of one of those things where like, there is not so yes, there is the constant clinical features, but there's not an actual constant cause. Does that make sense? So it's not like every single time a child is co-sleeping, they die. Every single time they're prone, they die. You know, it's not like that. So there's a lot of different causes, and there's just honestly not enough evidence. It's one of those things that there is not enough evidence to prove that it's this or that, and that's why we say sudden, unexplained. There's no rhyme or reason. And it's very important. Again, the death is not your fault. We need to make sure that the parents are not holding on to that and feeling that, taking ownership of that. Especially, again, when there's no really way to prevent it. There are ways that we can try to prevent it, and things that we have noticed have made more of an impact. But again, for example, breastfeeding. Not everybody can breastfeed. It's not every single caregiver mother can breastfeed a child. Yes, they cause prevention, but they also notice that breastfeeding causes prevention because breastfed babies tend to get up more frequently through the night, and if they're up more frequently, they're more checked on more frequently. You see how it's kind of like there's different things associated with it. And then pacifier, some kids just don't want nothing to do with the pacifier. Only one of mine did, of 3. I was a pacifier.
How does the
I'm not bitter
pacifier
about
help? How does the pacifier help? They just noticed that SIDS is more common in kids who don't use pacifiers? Is that what that's based on?
There's just some things that are just like no rhyme or reason. It just, yes.
So, are co-sleeping accidents still gonna be categorized as SIDS, like a parent accident?
Again, it's the asphyxiation part of it. So more common than like a parent rolling over on their baby, there'll be like incidents where they're sitting like in a recliner and they fall asleep with the baby, and the baby's head kind of falls into that crack.
Does that fall under SIDS though?
That would fall under SIDS.
Okay.
Because the airway is obstructed. And again, the parent's asleep, the baby's airway is obstructed. They're not going to cry, they're not going to make noise, they're not going to do anything. So it's just very sad. And again, we're going to talk about CPR education. So if a parent notices that their child is unresponsive, if they're able to do first aid treatment on them, it is less likely that they are to pass away. So we need to make sure that we're educating the parents when they go home from the hospital. And then discourage co-sleeping. Again, this is another no evidence one way or the other type of thing. I co-sleep sometimes. It just really depends. So you just have to be mindful of giving all of the evidence that you can and say this is what we believe will prevent and reduce the incidence of SIDS, but there is no long studied evidence that these are the main causes. So we just have to be very it's hard because these types of disease processes and incidents and things like that, they're hard to explain because when you have a patient, they're going to be looking to you to have the answers. 9 times out of 10, and I hate to say it, I hope I'm not the one to tell you this, they'll listen to the doctor, but the doctor comes in for 5 to 10 minutes. Who's there all day? So they'll be like, well, the doctor, before he left or she left, said, this. But that really doesn't make sense to me. Who's going to be explaining into detail? Who's going to be, I'm giving this medication for this reason. I'm doing this for this reason. You are constantly being the one who is the go-to person. So that's why it's very important that you're able to talk about evidence when you can, but also make it known that, like, this is what we know can help prevent it, but at the end of the day, there is no right or wrong answer. So again, when we let the parents know if it does, by awful, if it does happen, we just say there was no way that we could have prevented this. So we just need to make sure that we are supporting. Support. So with that palliative care as well, not only are we making sure that they are comforted, but we're making sure that they're supported as well. It's very hard. Saturday. I don't know, the days all run together. There's a 5-year-old boy on our littles unit, and he's very cute, but he's also very bad at the same time. And he doesn't understand a lot of things, and he takes medication like 3 times a day. And so the best way that I've found to give him the medication is to sing and dance at the same time. So, like, you just find little ways to, like, make things easier. And especially, like, you'll run into a large incidence of when you are caring for pediatric children. A lot of these children don't know love. They don't know people who support or care about them. So any positive interaction that you have with them will have a lasting effect. So that's just very important. And with their parents as well. Because remember, they're going to be frustrated. They're not going to understand. And any time that you take to explain to them and support them, or even just listen and validate when you don't have the answer, has a very large impact. So just always be mindful of that.